Assalamu alaikum. It is my pleasure to introduce ISN CME session in our conference. We have a long history of collaboration with Sheffield Kidney Institute. It started since 2006 by my fellowship in Sheffield Kidney Institute, and followed by my colleague Dr. Saham and Dr. Ahmed from Monofia. After that, 2008, we conducted a collaboration in the ISN Sister Renal Center program between Damanhur and Sheffield. During this Sister Renal Center, we gained a lot of improvement in our department. We applied with Professor Halawa parathyroidectomy project in our hospital and implemented now. And we conducted in collaboration with Professor Majid Nahas and Professor Rashad Barsoum Egypt CKD project for early detection and prevention of kidney disease, and conducted the CME meeting about histopathology, and Professor Arif Khawaja visited us before in Damanhur and conducted a workshop in Damanhur city. This session will be special session. It will be introduced by Professor Arif Khawaja and our colleague from Egypt, Professor Raghda Damanawi. And I let the chairman of the session and the moderator, Professor Yasser Abdel Hamid, Professor Salim Adib, and Professor Iman El Gohari to introduce the session. Welcome, Dr. Arif, and welcome, Dr. Raghda.
Thank you, Dr. Zaghloul, for your nice introduction, and I would like to congratulate you first for the success of your conference, as usual, and with more and more success every year. Coming to the last session, which will be with the ISN collaboration with Sheffield Kidney Institute. Case presentations will be presented by Professor Arif Khawaja from Sheffield Kidney Institute, who is well known to us and has visited Egypt many and many times with many and many lectures. He will introduce some clinical cases and hope that he is with us now. Professor Arif.
Hello, everyone, and welcome. My name is Arif Khawaja. I'm a clinical nephrologist at the Sheffield Kidney Institute in England, and it's a real pleasure to be with you here virtually for the Damanhur Annual Nephrology Conference. I want to say special thanks to Professor Gouda for inviting me. I've known him for many years, and he's always been very kind and very welcoming to me. So for those of you who haven't been to Sheffield, this is the Sheffield Kidney Institute. This is a city in the north of England, about 200 kilometres north of London, and we are in the middle of a big national park called the Peak District, and you can see a picture of that there. Now, I think I might know some of you from my previous kind of teaching and activity in Egypt. And the last time I was in Egypt, I took a train from Cairo to Alexandria for a conference that was organized by Professor Zaghloul. And this was a picture I took, and it made me laugh to see all the people clambering onto the roof of the train from Cairo to Alexandria. So they were happy memories for me, and inshallah after COVID we'll be coming back to Egypt soon. So for those of you who know me, I am a clinical nephrologist, and I've got an interest in clinical cases and clinical management, and particularly in glomerular disease. So what I'm going to do today is present three cases, three case studies, if you like, in glomerular disease: one on lupus, one on membranous nephropathy, and one on C3 glomerulonephritis. And I'll use the cases to discuss what I think are key issues in the management of these diseases. And then hopefully at the end of this recording, we can have a good discussion about some of the issues that are raised. So let me start with three cases, in fact, of lupus. So the first lady, first case was a 35-year-old Filipino lady who had a long history of SLE. She had mainly rheumatological disease, so mainly joint pains, and she was managed with methotrexate and steroids by her rheumatologist. The rheumatologist looking after her noticed that she had increasing hematuria and proteinuria, and her EGFR was completely normal, but they'd noticed that her protein-creatinine ratio had risen to 200 milligrams per millimole. So she had about 2 grams of proteinuria per 24 hours. The second case was a 30-year-old Caribbean man. Now, he did not have any symptoms of lupus at all. He was just incidentally found to have hematuria and proteinuria. Kind of blood's workup revealed him to have a positive ANA and low complements, and he had completely normal kidney function with an EGFR of 90, but again, slightly elevated proteinuria with a PCR of 200, so again about 2 grams of proteinuria. And the third case was a 40-year-old Caribbean lady who also had lupus. She was known to us, she had long-standing lupus nephritis, known class 4 disease, and she was on mycophenolate and steroids. Over the last year, her GFR declined steadily from 60 to 30 mils per minute, and her PCR, her proteinuria, had increased from 80 to 240. She was hypocomplementemic, but her complement levels were always low. Excuse me. So the first question is, should we do a renal biopsy? And I suspect most of you would think, of course, we've got to do a renal biopsy because we need to know what's going on with these patients. We need to have a baseline. And I think there is some degree of truth to that. So we did do a renal biopsy. And in the case 1, this was the lady with an EGFR of 90 and a PCR of 200 who was on methotrexate and steroids already, known to have lupus. Interestingly, despite having normal kidney function, she had a very proliferative renal biopsy, and that showed class 4 and class 5 lupus nephritis. Okay, and obviously then the treatment options, which we'll come on to, would then involve switching her from methotrexate to either cyclophosphamide or mycophenolate, or depending on where you work, Rituximab. So the biopsy definitely changed management there. Case 2, remember this is a young man who didn't have any symptoms of SLE, but just had a bit of proteinuria and a positive ANA. His kidney biopsy showed class 5 lupus nephritis, but in the absence of any extrarenal disease, he had normal kidney function, normal serum albumin, moderate level of proteinuria. We wouldn't ordinarily immunosuppress someone like that. And so the management for him would be an ACE inhibitor or an ARB. And our third lady was the lady who had known lupus nephritis for a long period of time, was on mycophenolate and steroids. And if you remember, her EGFR declined quite rapidly over the last year. And in fact, her kidney biopsy showed that she had really an end-stage kidney. She had class 6 lupus nephritis. So that was a lot of scarring, no activity. And in fact, the treatment for her, because she had no extrarenal lupus, would be to reduce the immunosuppression. So I think what these cases shows, very elegantly, is how a renal biopsy can be really critical to managing lupus. You've got 2 cases here, both with exactly the same GFR, normal kidney function, low levels of proteinuria. One needs a significant increase in escalation of immunosuppression with cyclophosphamide or MF or rituximab, and the other one doesn't need any immunosuppression at all. They just need an ACE inhibitor and ARB. And the third case, where you had a rapid decline in kidney function over the course of the last year, in fact, they had no active lupus nephritis at all. They just had progressive kidney disease from previous lupus and poorly controlled blood pressure. And actually, the treatment in that case would really be to reduce the immunosuppression, because this is nearly an end-stage kidney. So the biopsies radically change how you manage the patient. And that's really, in a way, what I've just described there is shown in this paper, where they, from this group from South America, Alvarado, and what she did was that she did protocol biopsies, and what she found is that in patients who were in complete remission or partial remission, some of them had very low levels of histological activity when you did a repeat biopsy. But even those with complete remission, some of them had quite high levels of histological activity. Okay, so you can be clinically in remission but histologically active. So do I think you should biopsy everyone with lupus? Well, the answer to that is no. And I think we should only, I think as Jen Bargman made the case in this really good paper from 10 years ago about the 10 common mistakes in the management of lupus, we should only really perform a biopsy on a kidney. We shouldn't be performing a biopsy on a kidney when it will not affect management. So we should perform a biopsy when we think it's going to change our management. And in fact, in this study from on the right-hand side from Holland, where they did protocol biopsies, they actually found that on the whole protocol biopsies added little prognostic information over clinical parameters. So I think when people talk about doing kidney biopsies to look at the prognosis, I'm not so sure about that, because I think proteinuria and EGFR are very powerful predictors of prognosis. I think a kidney biopsy is much more useful in terms of telling you whether to start treatment or sometimes whether to stop treatment. And that was shown again, this work from South America, where patients who were in a clinical remission 3 or 4 years after starting treatment were then rebiopsied. And you found that patients who had no evidence of histological activity when they were rebiopsied were much less likely to flare when their immunosuppression was stopped, whereas people who had histological evidence of activity, even though clinically they were in remission, were much more likely to flare if you stopped immunosuppression. So again, a renal biopsy, repeat renal biopsies may be important in terms of determining who can stop immunosuppression. But even in patients who have no histological activity, worth noting that around 6 patients in this group did eventually relapse. So how should you manage patients with lupus? Well, I think you'll all be familiar with this, and you know that the reason why kidney disease is so important to managing lupus is that it's a key determinant of survival, so that people with poor kidney function, with severe kidney disease, do much worse than people with mild kidney disease. And I'm not going to go over the histological classification of lupus because you all know that, but I'm just to say that when I'm talking about the management of lupus nephritis, from now on, I'm really referring to class 3 and class 4 disease, so proliferative lupus nephritis in association with class 5 disease. So when we think about, therapies that are used in lupus nephritis, it's useful to think about the kind of, if you like, the etiology of or the pathogenesis of lupus. So a lot of people speculate that in lupus, there is some problem with apoptosis. So there is some kind of disordered apoptosis, and you get spillage of apoptotic material into the circulation, of nuclear material into the circulation. Okay, that's taken up by antigen presenting cells. There's a kind of loss of tolerance that's presented to T cells and B cells, and ultimately that leads to production of autoantibodies. Okay. And there are a number of strategies we can use to kind of target, if you like, this process. So we can use calcineurin inhibitors, and we know that calcineurin inhibitors inhibit T cell activation to a certain degree by interfering with calcineurin. They also, very importantly, have a non-immunosuppressive effect in that they stabilize the actin cytoskeleton in the podocyte and therefore reduce proteinuria that way. You could give cyclophosphamide, which is a cytotoxic drug, which will inhibit T cells, B cells, and every cell that's growing. So that's another way of approaching lupus. You can give Rituximab, which is an anti-CD20 antibody, which will, of course, deplete circulating B cells. And B cells, as you know, will become plasmablasts and then eventually produce antibodies. You can give MMF, which, as you know, is a non-specific inhibitor of lymphocyte proliferation. Or you could give Belimumab, which is a treatment that's now licensed both for lupus and nephritis, and as well as for SLE. And this is a BLyS inhibitor, so that inhibits the B-stimulating lymphocyte factors, so inhibits, if you like, factors that that promote the maturation of B cells. So Rituximab depletes B cells, Belimumab stops B cells from, if you like, maturing. So what treatments can we give for, and I'm going to talk mainly about induction here. So we know right from the earliest bit of evidence we got was from the 1980s, from the NIHR studies, looking at cyclophosphamide and steroids and azathioprine. And we know from that work that cyclophosphamide is a very effective treatment for lupus nephritis. Whether you give it intravenously or orally probably doesn't matter, although with intravenous administration you are sure of adherence. And of course there is an increased risk of infertility as you get older, and there's an increased risk of cancer. So certainly once you're giving more than 25 grams of cyclophosphamide in total, whether that's intravenously or orally, your cancer risk increases. And you can give low-dose cyclophosphamide. So this is the Eurolupus study where they compared low doses of cyclophosphamide. So that's 500 milligrams IV every 2 weeks, versus high-dose cyclophosphamide, which was kind of 8 doses over the course of the year, and the doses were significantly higher than 500 milligrams. And what they found, there was no difference in terms of renal flares between the low dose, that's the LD, and the high dose, that's the HD, but the risk of infection was much higher in the high dose, as you'd expect. So I think you can use low dose cyclophosphamide, but I'm very conscious, obviously, that I'm talking to a group of nephrologists working in Egypt, where lupus may be more aggressive in kind of Mediterranean region compared to Northern Europe. And this study was mainly done in a low-risk Caucasian population. Okay, so yes, by all means use Eurolupus, but you may need to give more doses than 6 if you're dealing with somebody with severe disease. So then we moved on to the noughties, and that was the 1980s, and then the early noughties, so early 2000s, MMF came into being, and this culminated in a number of studies, but the main key study was the ALMS study, which compared mycophenolate to cyclophosphamide. And this found that mycophenolate was equally effective in inducing remission in about half of patients. But there was surprisingly no difference in safety between the two agents. And there was a signal that MMF was more effective in Black patients and Hispanics. Excuse me. And then the ALMS study went on to compare MMF versus azathioprine for maintenance, and found that MMF was superior to azathioprine for maintenance. Although azathioprine is not a bad drug actually in lupus, and it's perfectly reasonable to use azathioprine if patients can't tolerate myfortic or mycophenolate. And that's shown in this study, again, which is a low-risk European population. This is the Dutch lupus study, and again shown that mycophenolate was equivalent to azathioprine in this population in terms of maintaining remission. So for low-risk patients or people who haven't got aggressive disease, azathioprine is probably as okay as mycophenolate. What about rituximab? You remember about 10 years ago, rituximab, we used to call it vitamin R because everybody was saying we should give rituximab for everything. And it's worth noting that there is only one randomized controlled trial of rituximab in lupus nephritis, and that's the LUNA study, which I've shown the results here. And you can see that in the group that got, rituximab, that's in black, although the number of patients who had a partial response, there was an increased number of patients who had partial response. There's no difference in the number of patients who had a complete response. And this difference wasn't significantly different. Now, people have said maybe this study is underpowered. What is interesting is a lot of people like me and a lot of other people give rituximab all the time for patients with lupus, and we definitely see an effect. And one thing that's quite interesting is that when this data from the LUNA study was then analyzed a few years ago, what they found was that patients who got very effective B-cell depletion, so if you had no B cells sort of a year after the rituximab, you were much more likely to have a complete response. So about 47% of patients, 78% of patients had a complete response at 1 year. Whereas if you didn't have complete depletion of B cells, then your response rate was much lower. So unsurprisingly, if rituximab works by depleting B cells, and if you don't deplete B cells well enough, then you're much more likely to flare. And when we talk about rituximab, it's important to remember there's nothing magical about rituximab. Rituximab, in a sense, that rituximab depletes B cells, but so does cyclophosphamide. And it's really important you understand that, you know, cyclophosphamide will deplete B cells as effectively as rituximab and other cells as well. So the main reason to give rituximab is because you're worried about issues of fertility, you're worried about cancer risk, you've already given a lot of cyclophosphamide and you don't want to give any more because the cancer risk increases, etc. But, you know, in terms of efficacy, there's no reason to assume that rituximab is inherently going to be more effective than cyclophosphamide in lupus nephritis. And so what does the future hold? And I'm going to talk about two drugs now. I'm going to focus particularly on calcineurin inhibitors and belimumab. Okay. So remember, belimumab is a monoclonal antibody that inhibits the maturation of B cells. Okay. So this is very important data. This is looking at a calcineurin inhibitor, not cyclosporin, not tacrolimus, but something called voclosporin. Okay. Which is similar really to cyclosporin and tacrolimus. And this is the Aurora study. And this was published in The Lancet earlier in the year. And these are patients, 357 patients, so a big study with class 3, 4 or 5 lupus. As you can see, they all had pretty good kidney function. So baseline GFR was around 90 mils per minute. But of course they had significant proteinuria. They were randomized to MF and steroids, but the steroid dose was quite limited. I think they started at 25 milligrams a day or 20 milligrams a day and tapered very quickly. And you were then given placebo or adjunctive voclosporin. Okay. And what they found that when you look at complete renal response, which is defined as proteinuria less than half a gram, stable EGFR, and no need for any rescue steroids, voclosporin complete renal response occurred in about 41% of patients with voclosporin and about 23% of patients with in the placebo group. So very encouraging bits of data, but there are just certain things to think about in this. Firstly, that all the positive effects were predominantly driven by a reduction in proteinuria. And as we know that CNIs will reduce proteinuria in any kind of glomerular disease. So it's not really clear if CNIs or voclosporin in this case are really genuinely disease modifying or they're just simply speeding up remission. And it may be this group is going to publish a biopsy sub-study, and that will, I think, be important in understanding whether that is the case or not. The second thing to say is that it's likely that voclosporin will be expensive, and tacrolimus or cyclosporin, which we use, is going to be cheaper, and we've got much more familiarity with it as nephrologists, and it's very much likely to have the same effects. And thirdly, and I think this is important, is to realize that CNIs are nephrotoxic, and in the long term, and you saw here that the baseline EGFR was 91 now. So this may be very suitable for people with acute, with preserved kidney function, but you would be much more nervous about giving it to people with more advanced kidney disease, whether acutely or chronically. The second important study to talk about is the belimumab study. And this is, again, a long study where patients were given, patients with class 3, class 4 and class 5 lupus nephritis were given belimumab in addition to the mycophenolate and steroids or placebo. And the belimumab was given as an injection every month. I think it was an intravenous injection. And they looked at partial renal response and complete renal response, which again was defined a similar way by stable EGFR and low levels of proteinuria, so proteinuria less than around half a gram a day. And what you can see is that the belimumab group had a better partial response and complete renal response, although the effects were quite modest. So what's my take on belimumab? Well, it's going to be expensive. And the improvements, I think, in remission are modest. Unlike voclosporin, however, it's definitely, we can be sure it is a disease-modifying drug. So there is improvements in double-stranded DNA and complement. But finally, it may just be that the reason why belimumab works is because patients are getting the therapy. It's an intravenous therapy, and we know that patients with lupus, when they get better, tend to miss their medications, or there is a problem with adherence. So it may just be that the efficacy of belimumab is related to the fact that it's given intravenously. And both these drugs have now been approved by the FDA as the first licensed drugs by the FDA for the management of lupus nephritis. So what do KDIGO say? Well, KDIGO say everyone should get steroids with either mycophenolate or cyclophosphamide at induction. They say you can then give calcineurin inhibitors if you've got bad proteinuria, or you can give or you can give belimumab or rituximab in addition if people are relapsing or have sort of refractory disease. What do I say? So my feeling is that mycophenolate is really the backbone of therapy here for induction and maintenance. I think we need to be really careful about steroids and not give too much steroids and minimize steroids as much as we can. I think cyclophosphamide is a very good drug for people with severe and refractory disease, whether you give it orally or intravenously. And certainly, for example, if you had cerebral lupus or very proliferative lupus nephritis that was refractory to other disease, I would have no hesitation to give a cyclophosphamide. CNIs, I think, such as voclosporin, I think have a role perhaps in class 5 disease when you've got normal kidney function, heavy proteinuria, or when you have preserved kidney function in class 4 disease. Rituximab, I think, is probably useful in refractory disease or relapsing disease, or as a way of getting rid of steroids or using less steroids. And again, belimumab may be important as well in patients who haven't responded to the mycophenolate and steroids. I think one final thing to say about rituximab, certainly in the UK, rituximab is now generic, so we have biosimilar rituximab. So a gram of rituximab now in the UK costs around I think 300 English pounds or so. That compares to about 2,000 English pounds about 10 years ago. So I think if you have biosimilar rituximab available, that does change things quite a lot in terms, even if you're working in a low-income environment, it does change things a little bit. Okay, let's move on to, that's enough about lupus. Let's move on to the second case. I'll try and be a little bit quicker. So this is a 6-year-old lady, presents with nephrotic syndrome. She's got antiphospholipase A2 receptor antibodies, with a very high titer of over 600, and she's got an acute kidney injury with an eGFR of 23 mils per minute. She came to us from another hospital, and she presented with ascites, and they did a CT scan. The gynecologist who she presented to, they found that she had a renal vein thrombosis. You might be able to see that there, that tiny lucency in the renal vein. And she came to us and had a renal biopsy, and these showed this sort of classic thickened capillary loops with a spike formation, but also a sort of marked interstitial infiltrate. So she had dual pathology. She had membranous nephropathy, and she had acute interstitial nephritis. So I'm going to ask 3 questions and try and use the evidence to answer these. Did the patient need a renal biopsy? How should we use phospholipase A2 receptor antibodies, PLA2 as I'll call them? And should we immunosuppress? And if so, how? So PLA2 antibodies have now been around for since about 2008, and they're present in around 2/3 of people with membranous nephropathy. Very important to realize they can be present in people with idiopathic membranous, as well as people with secondary causes of membranous. And if you stain the glomeruli for the receptor, people in primary membranous nephropathy are much more likely to have receptor antibody positive as well. Okay. And the reason why it's important, so the other thing to say about this is that it is more or less 99% sensitive. So although it's present in 70% of patients with membranous, it's very, very specific. So about if you have a PLA2 antibody, you are somewhere between 99 and 100% certain to have membranous nephropathy. Okay. But it's also a marker of outcome as well. So if you become PLA2 negative, you're much more likely to go into remission than if you're PLA2 positive. Okay. But also, really importantly, is the PLA2 levels fall before the proteinuria levels fall, and the PLA2 levels rise before the proteinuria levels rise. So it's a very good way of figuring out whether you're going to go into remission or not. So if you go into, somebody has a high PLA2, you treat them, their PLA2 is negative, but they still have very heavy proteinuria, you don't need to worry, because with time, they will go into remission. Okay. So what do KDIGO say about biopsying then? They say very sensibly that if you have PLA2, if you don't have PLA2 antibody, obviously you need a biopsy. If you do have a PLA2 antibody and you've got normal kidney function, then you don't need a biopsy. If you're thinking about giving immunosuppressive therapy, then they suggest you consider a renal biopsy. But again, it's not mandated, so you don't have to have a renal biopsy before immunosuppressing. But what they do say is that if there is something unusual about the clinical presentation, then you should think about a renal biopsy. So for example, if the PLA2 has disappeared, but you're still persistently nephrotic, or the kidney function has declined very quickly, or there is some suggestion that you may have secondary membranous, like you have positive ANA or something, that suggests you might have lupus, then they suggest you should do a kidney biopsy. So I would say that you don't do a biopsy in patients with PLA2 who are PLA2 antibody positive unless there's a specific reason to suggest that you're looking for something else in the biopsy. So how do you manage people with membranous? Well, I think you'll be familiar with all this, and I'll just go in brief detail. Firstly, you need to exclude secondary causes. So you need to exclude cancer, you need to exclude autoimmune disease, and you need to exclude infection. Then obviously we give RAS blockade, we anticoagulate if the albumin is low, less than 20, give diuretics and statins, and we tend to wait and watch for 3 to 6 months. And if the proteinuria or the PLA2 is rising, then we'll immunosuppress. If it's falling, then we won't. And what immunosuppression do we give if we are going to immunosuppress? So I'm going to talk about 3 agents, really, that are the cornerstones of immunosuppression in membranous: cyclophosphamide, calcium neuroinhibitors, and rituximab. So cyclophosphamide or chlorambucil is equally effective. Really, cytotoxics are the only treatment that have been shown to reduce the need of dialysis, and that's why they remain an important part of the treatment you can give for membranous nephropathy. Obviously, they're very toxic therapies, but as you can see from this randomized controlled trial from India, cytotoxics here in the top line were very effective in preventing dialysis, survival without dialysis over a sort of 10-year period. So huge follow-up. This is a trial, I think, of around over 100 patients or so, compared with supportive care. So about supportive care, about 2/3, about 30% of patients or 40% of patients at 10 years had ended up on dialysis. What about CNIs? Well, if you have progressive kidney disease, so this is if you've got progressive membranous nephropathy and your kidney function is declining, cytotoxics help. This is in the red line here, but they don't stop progression, okay? And that's data from the UK membranous nephropathy study. But more importantly, calcium neuroinhibitors have no effect at all. So if your kidney function is already declining, I would argue that you shouldn't be giving those people CNIs, and that's very clear from the UK membranous nephropathy study. Okay, and what about rituximab? So this is a very important paper. This is the Mentor study that was published a couple of years ago now, and this took 130 patients, North American study with quite significant proteinuria, and it randomized them to rituximab. So you got 2 doses at baseline, and then if you weren't in remission but you'd had some response, you got another 2 doses at 6 months to cyclosporin. And if you look at 2 years, about 60% of the rituximab group were in a complete or partial remission compared to only 20% of the cyclosporin group. Okay, so clear evidence that rituximab is better than cyclosporin. So what did KDIGO say? KDIGO say really what I've just said already, really, which is that if you have low levels of proteinuria, so proteinuria is less than 3.5 grams, you've got normal GFR, your PLA2 is falling, just wait and watch, okay? If you're moderate risk, so your proteinuria is more than 4 grams, and your GFR is normal, but there's no fall in your proteinuria or no fall in your PLA2, you can think about Rituximab, or you can think about a calcineurin inhibitor. Okay. If you're at high risk, say if you've got more than 8 grams of proteinuria, GFR is less than 60 after 6 months of treatment, or you've got very high levels of PLA2 antibody, you definitely need treatment. And the treatment, what KD has suggested, you can have Rituximab, you can have Cytotoxics, so you can have CNI and Rituximab. Now, I would argue that the high risk group, I wouldn't give them CNIs too, because they have abnormal kidney function. We know from the UK membranous nephropathy study that's not a good idea. So I'd argue that those patients should get Cyclophosphamide or chlorambucil with steroids, and if they can't tolerate that, then they could, or if you feel that they wouldn't be able to tolerate it, then you could try Rituximab. And remember, if anyone presents, like our patient presented with a renal vein thrombosis, or with very severe nephrotic syndrome, or rapidly declining kidney function, just treat them straight away, and the treatment should be cytotoxics and prednisone. You can see there's a continuum here, and some of the patients will kind of move from one side of the continuum to the other. So it's a bit of a judgment call as to when you treat and how you treat. So going back to our patient, did the patient need a kidney biopsy? Now, this is an interesting point. So our patient was PLA2 positive. So what I would normally say is that our patient wouldn't need a kidney biopsy. But the reason why we did a kidney biopsy was that this patient had very rapid decline in their kidney function, which may be due to renal vein thrombosis, but in fact it turned out to be due to the fact they had an acute interstitial nephritis, and therefore will have needed some steroids as well as any other immunosuppression you're going to give them. How should we use PLA2? Well, we should use it to diagnose membranous, and we should use it to monitor the disease. And remember, it's more sensitive than proteinuria. And then if we're going to immunosuppress, how are we going to immunosuppress? Well, we have to immunosuppress straight away because this patient's got renal vein thrombosis, so definitely needs immunosuppression. And as I said to you, and as KDIGO said, if you have severe disease, you have to immunosuppress with cyclophosphamide and steroids. Okay, so that's case 2, and very quickly we'll go on to the final case. So this is a lovely young man, 18-year-old student, who presented with nephrotic syndrome and quite bad kidney function, so an eGFR of 25. He had a low C3, but the rest of his immunology was normal. He went on to have a kidney biopsy, and as you can see, there's a lobular appearance to the glomeruli, there are neutrophils here, and there's some sort of mesangial proliferation, matrix expansion, and the capillary walls are slightly thickened. So this person has a membranoproliferative or mesangiocapillary glomerulonephritis. When we did the immunofluorescence, that was positive for C3, and C3 was the dominant immunoglobulin. And when we did EM, there was sort of intramembranous and subendothelial deposits as well. Okay, so this person has C3 glomerulonephritis. Okay, and in England, we're very lucky, we have a national complement centre, and so we're able to send our serum off to, because a lot of these patients have abnormalities in their complement genes. So we sent the serum off to Newcastle in England, and the genetic analysis was negative at the time. And I know you won't, I don't know if you have that facility available in Egypt, but I do know that when I was last in Egypt, some centres were sending their serum to centres in Europe for analysis, and that can be very helpful, mainly in determining, in terms of counselling the family, in terms of determining risk for offspring. So I think the most important thing I want you to remember about mesangial-proliferative or mesangiocapillary or membranoproliferative glomerulonephritis is the classification about it. So forget about the MPGN types 1, 2, and 3. Okay, forget about that. If you have an MPGN pattern of injury, the first question you need to ask yourself is, what does the immunofluorescence show? Okay, and if the immunofluorescence is predominantly immunoglobulin positive, and this is some kind of immune complex disease, Then you look for secondary causes such as monoclonal disease, autoimmune disease, infections. And if the search for those are negative, then it's you call it idiopathic IgG immunoglobulin positive MPGN. Now, if complement is the most dominant feature on the immunofluorescence, is the most dominant sort of staining you get on the immunofluorescence, then you know it's a complement-mediated disease. And you can then call this C3 glomerulopathy or C4 glomerulopathy, depending on whether C3 or C4 is the most dominant form. And C3 glomerulopathy can then be divided into C3 glomerulonephritis, which is the case we had, or C3 dense deposit disease, which can only really be diagnosed by electron microscopy. So you have huge ribbon-like structures within electron dense material within the basement membrane. And if the immunofluorescence is negative for immunoglobulins and negative for C3, then just think of other things, and that may be kind of antiphospholipid antibodies, sickle cell anemia, or HUS, or TMA. But this diagram, or this flowchart of trying to look at the classification of MPGN, I think is really important, because if you can remember that, then you can understand how to approach both the diagnosis, investigation, and the management. C3 glomerulopathy, I'm not going to talk about complement because we don't have time, and I'm not an expert on it, but it's mainly characterized by a genetic or an acquired dysregulation of the alternative pathway, which results in products of the alternative pathway depositing within the glomerulus, okay, and mediating damage. So how do we treat? Well, the best evidence is for mycophenolate and steroids, and the evidence base is very poor because it's a very rare disease, and the best evidence we've got comes from the Spanish glomerulonephritis study, glomerulonephritis registry, or the GLOSEN registry, and they found that in patients who were given MMF and steroids, they did much better than patients who got steroids alone, or steroids in combination with cyclophosphamide, or some other immunosuppression. And the kind of group that did worse were the people who had no immunosuppression. Okay, so mycophenolate and steroids represents the sort of best medical practice at the moment, but in the future there are a number of trials of different complement inhibitors, and that may change how we manage this disease. So what happened to our patient? Well, our patient did really well. So the GFR dropped to nearly 20, started mycophenolate and steroids, gradual improvement, so between 60 and 80. And you can see a significant decline in proteinuria, about 7 grams. So proteinuria has not gone away. And he's got about PCR of under 150, so about 1 to 1.5 grams of proteinuria a day, but doing very, very well. Got a first at university in engineering this year, and he's going to be a very clever engineer, so he's done really well. I think the most important thing to say about all the cases are it is important to remember that you can always kill a patient with your treatment. When you're giving immunosuppression for glomerular disease, you can always kill a patient. So the balance that you've got to strike is between trying to get disease remission and trying to stop the complications of immunosuppression, whether that's cardiovascular, diabetes, sepsis, or fractures. And I have to say that in the current era, I think uncontrolled complications of immunosuppression is a really, really big problem, really. So just to finish, what did I say? So for lupus nephritis, I said minimize steroids, mycophenolate is the backbone of therapy. I think you all know that. Cyclophosphamide for severe disease, I think you all know that. CNIs for those with proteinuria, and voclosporin is now licensed. And rituximab, perhaps for people who haven't responded, or belimumab for people who have not responded, or people who are relapsing frequently, or people who have problems with adherence, because you can give it intravenously and it will last a long time. What did I say about membranous nephropathy? Well, I talked about PLA2, just to be aware there are a whole load of other antibodies that I haven't talked about, but PLA2 is probably the most important one at the moment. And I would say PLA2 is critical in the diagnosis and management. So if your lab doesn't have PLA2, it's really worth getting them to do that, because that will save you and your patient a lot of money, I think, and a lot of unnecessary therapy. Cyclophosphamide's probably got the best evidence base in terms of outcomes on progression, but obviously the side effects with cyclophosphamide are pretty significant. So rituximab is, if you like, your second choice if you can't have cyclophosphamide for whatever reason. And certainly rituximab is superior to calcineurin inhibitors, particularly in people who don't have normal kidney function. What did I say about C3 glomerulopathy? Remember that you need immunofluorescence and electron microscopy to make the diagnosis, and you absolutely need to use the sort of, forget about the MPGN 1, 2, and 3 classification. Send blood for complement if at all possible, and the optimal treatments are for steroids, with steroids and mycophenolate. So with that, I'd like to say thank you very much, and then hopefully I'll be able to take some live questions. I'll just leave you with some pictures of Alexandria the last time I was there a few years ago. So not far from you in Damanhur, I think just up the road. This is this guy doing some fishing. You can see the waves were really coming in on this, I think it was a February time, and this is a glorious sunset by the Palestine Hotel where we stayed. And finally, I'd just like to say thank you very much to the ISN, in particular to Dr. Hamida and Professor Zaghloul for inviting me and for all our collaboration and friendship through the years.